2023 exams. And the question goes thus: define health education. What are the importance of health education? What are the barriers to health education? Then there's a scenario of a man with oculocutaneous albinism. Patient came to the clinic with an erythematous lesion on the right forearm. How will you educate him about his condition and what to avoid? The World Health Organization defines health education as any combination of learning experiences that are designed to help individuals and communities improve their health by increasing their knowledge or influencing their attitudes. Because knowledge alone may not be powerful enough to motivate change, health education works to enhance knowledge, attitude, and skills to positively influence health behaviors of individuals and communities. So health education is simply a combination of learning experiences which are designed to help both individuals and communities to improve their health by increasing their knowledge and or influencing their attitudes. The Alma Ata Declaration also defines health education as the process of communicating health information to people, and is aimed at encouraging them to want to be healthy, to know how to stay healthy, to do what they can, both individually and collectively, to stay healthy, and to seek help when they need it. So what's the importance of health education? It improves the health status of individuals, families, communities, and of course, overall, the states and the nations. It enhances the quality of life in all people. It reduces the incidence of premature deaths. It has a positive impact of finances and economy. Of course, the more healthier people are, they're able to work to improve the economy. It motivates people to maintain and improve their own health. It encourages health promotion behaviors among patients, and it also informs the public about advances in medical science, the uses and its limitations. What are the barriers to health education? The first one talks about lack of understanding of the principles of adult learning. Okay, so when the health educator fails to understand the principles of adult learning, he may not be able to communicate the information effectively. He needs to know that adults are autonomous and self-directed. Adults learn from previous experiences. Adults are goal-oriented. They need to be shown respect. They need motivation to be able to learn. And they are practical, focusing on the aspects that are most useful to them and neglecting the aspects that they feel are not useful to them. Other barriers include lack of time. If a health educator has so many patients to see, he tends to rush. Therefore, he's not able to communicate effectively. Lack of confidence. If the educator is not confident in the knowledge or information or skill that he has. Lack of motivation, maybe due to poor remuneration and all that, just wants to do the job as quickly as possible and leave. If there are scheduling problems, so many patients are given a 10 a.m. appointment. So because of that, there are so many people waiting. The health educator has to move fast to be able to cover all the people he has. If there's inadequate information from the healthcare personnel, if there are environmental barriers, for example, if there are 2 or 3 persons in a consulting room, sometimes one patient may be overhearing what the other person is saying, if there is noise from outside and all that. If they are hearing or seeing difficulties, if the patient has a hearing difficulty and the health educator needs to maybe shout to be able to communicate, after a while he may not be able to communicate all he wants because he feels the person is not understanding him or is not hearing him appropriately. What are this patient education? The first one is to assess, to plan and implement patient education, then also to develop teaching methods for implementing patient education. To develop teaching material, then document education and learning. How do you ensure that learning has taken place in an adult? There are 4 of them, although this is not part of the question, but I just put it. The first one is reinforcement. This is to repeat what you have mentioned in another way. Then to ask the patient to repeat what you have said, that's called retention. Then give the patient beneficial reasons to adhere. That's motivation. Then finally, it's transparent, to be able to transfer the information from yourself to the patient. Okay, then the next question is a scenario of a man with oculocutaneous albinism. The patient came to clinic with an erythematous lesion on the right forearm. How will you educate him about his condition and what to avoid? The differential diagnosis of the man's lesion include actinic keratosis, squamous cell carcinoma, basal cell carcinoma, melanoma, and a solar lentigo. So the first thing we need to do in educating this patient is to tell him about the disease condition, tell him about he needs to be seen by a dermatologist and undergo follow-up by the dermatologist. He needs dermoscopy and he needs biopsy of the lesion. Tell him the modalities for treatment and the outcome.
Dr. Charles, excuse me.
Yes, ma'am.
Yeah, this station, you need to have a simulator and then educate him. It's not that you just give the stuff. That is how the station is. So did you think about that?
No, I did not think about that.
So it's a communication station. You have to get a simulator and discuss it. So I don't know if we can do that now.
Okay.
Yes, we can.
Okay, I don't know if somebody can please volunteer as a simulator that we can do that. I don't think about it before now, so I did not ask.
Dr. Kalamama, are you on the call?
Okay. Yeah, I am. Okay, I can do that for you.
Okay.
Good morning.
Okay. Good morning. Good morning, sir.
Good morning.
Sorry, before you start,
My name
sorry,
is...
sir, am I supposed to time him, like maybe give him 10 minutes or he should just keep talking?
No,
Hello,
you time them.
Okay, 10 minutes.
10 minutes, yes.
Okay, thank you. Okay, you can start.
Okay, good morning, sir.
Good morning.
My name is Dr. Charles Okore. I'm here to see you this morning. How are you today?
Very well, thank you. And you?
I'm fine, thank you, ma. Thank you, sir. I hope the setting, this place is okay for you. Would you like to move to another room, or you're okay the way we are?
I'm okay the way we are.
Okay, is there any other person you would like to join us in this consultation, or do you think we can go ahead this way?
I think you can go ahead. I'm comfortable the way I am.
Okay, thank you very much, sir. I was told that for what I can see, that you came with a lesion on your right forearm. I hope that's correct.
Yes, that is correct.
Okay, sir. How long has this lesion been there?
It's been there for like 2 months now.
Okay, all right. And I don't know if the lesion has been causing you some distress or some issues. I don't know how you see the lesion.
I feel very uncomfortable. You know, I'm a lady. I feel very uncomfortable with it.
Okay. I'm sorry about that. That's why we are here. We'll do our possible best to ensure that we know what it is. Okay, but before we go on, I would like to know, what do you think that is? What do you know about it? What do you think the lesion is?
I really do not know what exactly it is, but before now I was educated that I'm supposed to use some certain creams on my body. I shouldn't just come out under the sun, but I have not been adherent to that because at the point I got tired. So I don't really know what exactly the skin lesion is.
Okay, all right. Okay, before I go ahead to tell you about the skin lesion, I'll tell you about some things that you need to do. Like I say, it's very important that you always seek shade to avoid sun exposure during the peak hours of sunlight. Okay, it's also important that you use protective clothing. It's important that you wear hats, you wear shirts with a long collar if you have to go under the sun. Okay, you wear long sleeve, long pants, or socks. Okay, It's also important that you apply sunscreen. If you need to use sunscreen with at least a high sun protection factor. Okay, then there are some drugs. Also important that you a doctor prescribes your drugs, because there are some drugs that can increase photosensitivity. That means that make your skin more sensitive to sunlight. Okay, so you need to avoid those drugs. I don't know if you can repeat these things I've said to be sure that you understand them.
Okay, you said I shouldn't go under the sun. My skin should not have direct contact with the sun. I should use maybe screens. I should use umbrellas. That there are some creams that are kind of protective for my skin to prevent damage to my skin. So basically not having direct contact with sunlight. That's just what you talked about. Thank you so much.
Excellent. Thank you very much. I'm glad you understood that. Then the next thing I'll talk about is the lesion. Okay, we will need to examine the lesion very well, look at it under our demoscope. Okay, then also we need to take a biopsy of the lesion. Biopsy simply means that we'll take a part of the lesion and send it to the lab. Okay, we will do that if it is okay by you. I don't know if it's okay with you.
Very okay, Danny.
Okay, thank you very much. Then also, there's other things I need to tell you about your skin is you need to see a dermatologist frequently, every 6 months. Okay, every 6 months. Then apart from that, you also need to look at your skin from time to time, what we call skin self-examination. And doing that, you are looking to see if there's any lesion that is like that one, looking out for new lesions. Okay, then you're also looking out for any change in old lesions. Okay, any changes will need you to come see a dermatologist sooner than your recommended appointment. Okay, I hope you understood what I said. Can you please repeat what I said so that I can be sure you got it?
Okay, you said I need to do a skin test to know what exactly is the problem, and then I need to see a skin doctor for further evaluation, and from time to time I need to be coming to see them to find out if there's any change in my skin color or any change in anything, that I should keep a check on my skin and make sure I see a skin doctor on a regular basis.
Excellent. Thank you very much. Yes, so you need to see a skin doctor on a regular basis and also look at your skin. Okay. Now, the next thing I would like to talk about is your eyes. Okay. So you need to also see an eye doctor, that's an ophthalmologist, for regular eye checks and in case you have any eye complaints. I hope that's okay by you.
Very fine.
Okay, excellent. Then there are also support groups. I don't know if you are aware of them. Support groups for support groups both in Nigeria. I believe in this our city. There's also a support group here that you can be part of, so that you are with others and you encourage yourselves and all that and share your challenges. Okay, so if you don't mind, I know the president of the support group. I can link you up with him so that you can also become a member. I hope that's okay by you.
I don't mind. Thank you so much.
Okay. Then is there any concern you have that I may not have addressed in this consultation?
I just want to know, this lesion I have, is there a cure to it? Hope it's not permanent.
Okay. Thank you very much for that question. Once again, I'll say I'm sorry about the distress caused you by the lesion, but it will depend on what we find after the evaluation. Okay, so we'll be able to give you more information when we can tell you exactly this is what the lesion is, whether it is benign, whether it needs to be removed, whether it needs more treatment and all that. Okay, but I'll want to reassure you that we will do our possible best and to ensure that you are properly and well taken care of. I hope that's okay by you.
It is. I'm okay by that.
Okay. All right. Thank you very much. So I will give you an appointment. We'll do the investigations that we have scheduled to do. And I'll give you an appointment for a week to come back to see us in the clinic. I also drop my number with you in case you have any questions or any complaints or anything you would like to tell us after now.
Thank you. Thank you so much, sir.
Thank you very much. Thank you very much, Ma. Thank you. All right. See you next time.
All right. Thank you so much, Dr. Charles, for that beautiful presentation. And even the counseling session, you ended before the time. Thank you so much. Okay, so now we'll take comments and questions from the participants first. And then thereafter, our teachers will come in. Okay, let me make my own comments. It was a very beautiful.
Dr. Charles, please, thank you so much. Can you show us the question you are presenting so that when people are making comments or ask, they will know if thank you so much. Go ahead, please.
All right, ma. Okay, so let's also keep the thanks coming on the chats. Can drop our chats, and then can raise our electronic hands. Okay, there's an electronic hand up. Okay, let me just make my comment before you, Dr. Linda. Thank you so much. It was a beautiful presentation. Okay, to the third question, the barriers. I just want to suggest if you can divide the points you noted into healthcare provider factors and then patient factors. If it's possible to classify them that way. Okay, then for the counseling session, I think you followed the Spikes model. It was so beautiful, but then you didn't ask the patient what's her level of education, and I noticed that you're using a lot of medical jargon. Because recently I was having a conversation with my younger sister as a lawyer, and I mentioned there's a lesion on the skin. She asked me what's lesion, so I don't think a layperson will understand what lesion is. And then you said examine, demoscope, dermatologist. I don't know if you are supposed to, like when you mention the word, you tell the person in layman's term what it means. And if there's another word you can use in place of lesion. And then when you started talking about the albinism, I don't know whether you told the patient what albinism is, maybe like a sentence or two, that is caused by absence of production of melanin. Okay, so those are my comments. Thank you so much.
Thank you for your comments. Thank you.
Okay, Dr. Linda, go ahead.
Okay, thank you. Good morning, my teachers. Thank you, presenter, for your wonderful attempt. Thank you, Dr. Ekili, for your comments as well. So my comment is basically on the counseling. Like Dr. Ekili said, you had a lot of medical jargons and you didn't tend to explain these things to the patient. For example, this patient is coming with a lesion at a sun-exposed area. You just told the person you wear protective clothing. What is protective clothing? You didn't tell this person that this clothing has to be long-sleeved, to cover, exposed areas. And you told this person to apply sunscreen. You also didn't tell the person how often, because it's not just about application of sunscreen. If you put sunscreen like in the morning and you go out and you don't reapply, it's as good as you not even using it. So how often is this person supposed to use sunscreen? Sunscreens are supposed to be used even when the person is indoors, and that you didn't also tell the person, because what you're just trying to avoid is UV radiation, which can still come in through, the windows or whatever openings there are in a building. So application of sunscreens is supposed to be within 2 to 3 hours. So they have to reapply sunscreens, whether they're indoors or outdoors. These are some of the comments I wanted to make. And also, I didn't hear you talk about support groups because it's obvious this person doesn't really have education about albinism on its own. And, there are so many support groups for people living with, people with albinism. Apart from groups, there are associations globally, locally. So I also thought you were going to also talk to the person about it. Thank you very much.
Thank you so much, Dr. Linda. Okay, Dr. Aminu Bashir, please go ahead.
Thank you very much. Thank you, the presenter. Thank you, the facilitator and our teachers. I think part of the comments I intend to make has been made by the two earlier people, Dr. Linda and Dr. Ekeli. However, in addition, it is going to be so important while trying to invite the patient. You use Spike, obviously. So while trying to invite, having gotten the setting right, you've tried to assess the perception of the patient. The invitation aspect is totally missing. You need to request from the patient to what extent, what exactly does the patient want to know? Because to some extent, the patient may be interested in, okay, this is what I want to know, this, but you just go out there, you want to give the whole of the information, it may like not be the whole of that the patient wants to know. Of course, in the knowledge base, you have to display your knowledge and the strength, the extent of your knowledge base about the topic, but you must be able to address that particular aspect that the patient is really, really interested in. And of importance, you know, is to say spike, then ICE. At the end of the day, you still want to summarize the whole of what you have said when you are done. Excuse me. When you're done with all of the discussion, the patient has been able to recall and intermittently. You did fantastically well in that. You didn't want to give the whole of the information, and at the end of the day, you now tell the patient to try to recall. It will be a lot of problem, but at periodic time, you did that good. But at the end of the day, when you're done, you now want to give a brief summary of the whole of the discussion that has just happened, and you want the patient to now recall that summary as well. But by and large, it's a fantastic one. But if you look
Hello, I can't hear him again.
Me too, I can't.
Okay, I can't hear him. Okay, Dr. Bashir, I think we lost you. Okay, let me just, okay, while we're waiting for.
Okay, he's there, but it's
can you
muted.
hear me?
Okay, I can hear you now.
Okay. Sorry, I don't know to what extent did you stop hearing me? I don't know. I wasn't audible again.
When you were talking about how he should give a summary, like a grand summary at the end of everything.
Yeah, I think I'm already done with that point. Ideally, after you use your outline of spike, then there is this ICE. Okay, like you want to check the insight again, you want to make sure you address the concern, then E. Yeah, of course, you are empathic. Then the last S, IC, is the last S is to make a grand summary of the whole of the discussion that has just happened between you and such person. And the last point I was just making before I went off is was that you already told in the question, I don't know if that was verbatim in the question, that this is an oculocutaneous albinism. Of course, you wanted to take a biopsy, you wanted to refer the patient to an ophthalmologist, but you still let the patient know some of those things that the patient may expect in an empathic manner, that you want to prepare the mind of the patient, and you pause, you want to see the reaction of the patient. But by and large, it was an extensive attempt. Thank you very much.
Thank you so much, Dr.
Thank you,
Bashir.
sir.
Thank you so much. Okay, so you have a lot of thanks on the chat, and then Dr. Conte, okay, also took note of medical jargon, uses a lot of medical jargon. It needs to be as simple as possible. Thank you everyone for your comments and contributions. Okay, so I'll hand over to our teachers now.
Thank you, Dr. Kelly, for background noise. Thank you, Dr. Charles. That was quite a fair attempt. Thank you so much. I must appreciate Dr. Linda. She made my job relatively easy. She had made comment from the dermatology aspect. So thank you, Dr. Linda. We appreciate you. Thank you so much. So just to reiterate what she said, was a fair attempt. It was a fair attempt. Dr. Kalamama was so friendly that both of you were gisting. So maybe that was one of the reasons Dr. Charles missed some of the things he could have talked about. Dr. Kamara, I didn't know you had such a nice simulator. Maybe we start getting people from this site that do this exam, so that they would start training us on how to simulate it. Then I must also appreciate Dr. Charles. I know when they told him to get a simulator, some people will be taking oil, will be off balance, but he just kept at it smoothly, and so it shows that he's doing it. It's something he's doing already. But we'll just appeal going forward, when you do counseling station with your patient, always try to use Dr. Chitu always say use pidgin English. That way you are forced to use simple words, even if the person in front of you, because it now became a grammar quiz competition between you and Kolamama. Both of you are moving stuff. So maybe that's why you just kept at it, because she seemed to be also moving stuff with you too. So but if you are using pidgin English, ideally before you know, you just get into motion, you just start saying things in layman terms, because irrespective of who they place in front of you, always use the layman terms. And if you have any they give you any scenario, start, and if you already know what that thing is, like now when I counsel my patient on punch biopsy, I let them know the instrument I'm going to use is like a biro. I'll show them a biro. This is like this thing, it's not bigger than this, so it's very simple. And I'm going to make that area, fit pin, or just ingest something small there for you, fit pin. I'll use one very tiny needle like this that diabetes patients use, that use it every day. So for them to use it every day, that shows that it's not painful. So you just try to say it in such a way that the patient understands. So by the time you're done and you are done, there's no fear, or you really address their concern. Then also, there's something when the patient asked you about the skin, she actually asked you about the skin condition, and there's a way you made it like not something so important. That is also not good, because somebody that have a lesion, erythematous lesion, that's red, erythema, red lesions on the forearms, unexposed area, that will tell you that this is either a precancerous lesion or is a cancer lesion. So that way, when then they give you things like this, so you do not downplay on it. And if you want to use dermoscopy, I'm sure you know what dermoscopy is. It's a digital microscope. So it's something that magnifies your skin, just in case something like this comes up again. Something that magnifies your skin. So you don't have to say, we're going to use them. We're going to use a particular tool, like an instrument that shows what is happening in your skin. Those small things, that makes it bigger, so we'll see it better. Then most likely we'll take a little from it and we'll confirm it. Is this a good thing or is it a bad thing? Whatever it is, but know something, we can manage it. So don't just go and tell them, don't worry yourself, everything will be fine. So because you downplay it a little, and albinos and skin cancers, especially those that are not using that are consistent with sun protection, they are 5 and 6. They're usually prone to having a lot of cancers. Even when you move one, they go back and they have more cancer. So squamous cell carcinoma, basal cell carcinoma, those precancerous lesions, they are prone to having it. So we usually advise sun, and the way we went about the sun protection too. But Linda talked about some. Let me just quickly talk about some that you missed. When you're talking about sunscreen, what is the SPF? You are from a wonderful center that have good dermatologists. Maybe I just met one of them to just guide you on sunscreen use. Then the SPF, what is ideal SPF? And which brands? Sometimes we even go as brand. You might not go as brand for your exam, but you just say, please go for recommended brands, so you don't buy fake. Because the person is using a low potency sunscreen, or the person is buying using fake, obviously the person will get results. So after the SPF, talk about the different method, then we usually emphasize something. Irrespective of, if you like, bath with sunscreen, use it every 2 minutes if you want, but sun protection is significant. So you talk about the clothing, the time of the day that they should be out, the peak hours of sun, they should avoid it as much as possible. Then lighting in their room should be as dim as possible. Windows, they should not be so close to the window. There are some protections. I know of somebody, a patient that, not the patient, a colleague, with their skin is practically spotless, because even her car, she shielded her car. There's this car shield that they have. This usual thing now, what they call it again, that give it dark look. So those are general things. So, thank you, my sister. So tinted glass, just make that car tinted. With doctor's permission, nobody will harass them. So even sunshade, everything, the clothing, the colors of clothes they should even wear, and the fabric also, all these things comes into play. But always emphasize the type of hats, not just face cap, not just one tiny looking hat. Let them know it's going to be wide brain. Because most likely, whoever is going to manage this station is going to be a specialist. So by the time you start seeing some of these things, the person is already so happy, The person will be so happy and will give you, just be so happy. For the person, very generous with his scores. because you are saying the bed. When you are saying some things, look at what be this now. So the person might how would you be saying this? You just irritate the person really. If the person is not a specialist, the person will be like, wow. But if the person is a specialist, I say, no, these are basic things. You just tell these are basic things my medical student knows. So you should know it too, as a fellow. So they will not be so happy. So why brim art? It should be wide that covers. So we'll say covers beyond the ear. You know all these things that these farmers use. This thing that look like palm front that they used to make cap, something as wide as that. But you let the ladies know that they also found a simple cap that is like that. But you show them because they will not know. But just say wide rim in exam, just say wide rim hat. But I'm saying all of this just in case this is repeated, you will all learn on how to answer it so that there will be no confusion. But overall, as I said earlier, I love the way you went around it. You're actually a very stuffy guy, so I'm not surprised. You're actually very intelligent, so I'm not surprised. You went about it well, but this is just to guide you on one or two things, just in case it comes up again. I must appreciate those that commented on the medical jargons you use. Thank you so much for all our commenters. I don't know if any of our facilitators, Chief Cookie, Banse, Chitu, Remigos, Fatima, Kopi, Success, Dahatu. I don't know if anyone have any comments before we move to the next question. Dr.
Hello?
Fatima, go ahead.
Oh. Dr. Fatima can go ahead. No problem.
Okay, well done, Dr. Charles. Although you were taking on awareness, but that is how it's going to come in the exams. You will not know what you'll be asked. The big omission is you didn't talk about the albinism at all. You need to educate the patient of what albinism is, that it occurs as a result of deficiency of this melanin. And why is melanin relevant? It protects from the UV rays and all that, protecting the skin from damages, skin rashes, skin cancer. So now that it's absent, she lacks it. That's why she's having all this. So in simple terms, you have to explain to the patient what is albinism before you even go to, so that she will easily understand why she is trying to protect the skin, because she lacks the pigment that is relevant for the protection. So that is my comment.
Thank you, Dr. Fatima. Thank you so much. Dr. Emugusa.
Yeah, thank you so much. The presentation has been beautiful and all the comments wonderful. I just wanted to add to what everyone has said that, yeah, he made attempts to get the consent of his client, but it was just once, just asked for once, and she gave one consent. Please, sometimes, especially I think in the exams, they will tell the simulators to just give you the thing in aliquots. When you ask once, they will give you one. If you don't ask again, that's all. And the simulator might have several concerns. And then if you look at the Dr. Corey actually finished on time, and he had time to ask more and to talk more and to get more. Okay, so please always try to ask for more. After addressing one, say, okay, do you still have any more concerns? And if they have, they will tell you, and you address it again. Okay, continue to ask until they say no, I don't have any more concerns. Then you know you are home and dry. Thank you.
Oh, thank you, sir. Thank you, sir. Don't know if there are any more comments before we move to the next question. Okay, there's no more. Dr. Charles, thank you so much. Thank you, sir. We appreciate you. Thank you so much. Dr. Kele, thank you. So the next question.
All right, thank you, ma. Thank you, our facilitators. Okay, Dr. Fit. Dr. Charles, please don't share your screen. Dr. Fit, please can share your screen. All right, please go ahead. You have 10 minutes.
Okay, good morning, facilitators and teachers and colleagues. I'll be taking practice question 1 for 2023. The first question is, a 45-year-old man with 1 year history of leg swelling, easy fatigability, and difficulty with breathing. The urea is elevated, creatinine elevated. The PCV was 15%. He has financial constraints. His ailment has affected him psychologically because of the likely cost of his care. A, mention the themes you would involve in his management and why. B, his cousin died of kidney disease 2 years ago. He is now depressed because he thinks he has the same disease. What would you involve in this stage and why? C, there was a delay in initiating hemodialysis because patient declined as he was now anxious. What teams would you involve now and why? D, what investigations would you do in preparation for his hemodialysis? E, what is the definitive treatment? F, would you enroll him in a cohort study? If yes or no, state the reasons for your answer. G, what are the poor predictors in CKD? Okay, the answers. A multidisciplinary approach is required in this patient management. It will involve nephrologists, cardiologists, hematologists, clinical psychologists, referral to the vascular surgeons. For the nephrologist, this patient seemed to, from the presentation, he has a chronic kidney disease. The symptoms has been on for about a year. It could be chronic kidney disease from varied causes, and with the very low PCV and the symptoms that are also present, seems he also has anemic heart failure. So nephrology consultation or referral will help manage the renal disease and provide guidance on renal replacement therapy. Also, early referral to vascular surgeons for well ahead of time. Early referral to transplant or renal transplantation preemptively will prove just ordinary dialysis alone wouldn't take care of all the renal functions. And like I said, the cardiologists will also be involved. They will help managing the heart failure and also possibly do echocardiography for the patient, because accurate assessment of the left ventricular systolic function is it helps in determining the cardiovascular, the tendency to have cardiovascular disease, and also if there's left ventricular systolic dysfunction, which is not well managed, it predisposes to increased mortality in CKD patients. Hematologists will also be involved in the management of anemia in this patient. The pharmacists will also help in managing the patient's medication regimen, which includes health medications. If he eventually does hemodialysis, some of the medications may be dialyzable and some not dialyzable. So when pharmacists will help in guiding patient medication dosing. Dietitians will also be involved in managing the patient to offer dietary counseling and renal diet, which it's been shown that when the patients adhere to the proper diet in CKD, helps to improve the outcome in these patients. He's said to have financial constraints, and so will require the services of the social welfare in the hospital that will help maybe get waivers for him for some investigations or even treatments, and also reach out to philanthropies or NGOs that may be willing to support these patients in their treatment. The family and caregivers are also not left out. Kidney support group volunteers and clinical psychologists. I don't know if this question came as in every information was given like this, or if it was given in batches, because there's also another, the B option said he is now depressed, and what teams would you involve? Because he's depressed, he will require the services of psychiatrists, psychiatric nurses, and clinical psychologists. And because he also said that his cousin died of kidney disease, and so he's afraid he has the same disease, there will be need for genetic testing and genetic counseling too for him and then his other family members. The C option is now unsure and declines hemodialysis. What things would you involve in this case? We require the services of counselors, health educators, like nurse educators, and then even group education with other patients with chronic kidney disease will help to educate the patient and the family, and then help to allay their fears, their anxiety. And they can be trained peer educators or volunteers who can also come and educate the patient. The support groups will also help in reassuring the patients and their families and helping them cope with the demands of end-stage renal disease and its treatment. What investigations will be done in preparation for hemodialysis? Well, in this patient, investigations in preparation for his hemodialysis would have necessarily involved maybe those investigations for CKD, such as those for screening, staging of the chronic kidney disease, measurements of the proteinuria, maybe using urinalysis or albumin, urine albumin creatinine ratio, measurement of the kidney function with and the estimation of the eGFR to help know what stage of kidney disease he has, and then also guide a decision on the commencement of the hemodialysis. Investigations to assess the electrolytes and other complications of kidney disease will also be important. Blood tests, such as full blood counts to look at the level of anemia and the need for use of blood and blood products or erythropoietin. Also, red cell indices to know the type of the anemia, such as iron deficiency anemia, and the need for iron supplementation. Then blood tests for viral screening for HIV, hepatitis, and hepatitis B and hepatitis C, to also know if the patient will require a special dialysis machine. Imaging, to do ECG in these patients to help look at the cardiovascular status and if there are electrolyte changes in the ECG too. And then the echocardiography will also be important in this patient. What is the definitive treatment? The definitive treatment is renal replacement, renal transplantation. Would you enroll him in a cohort study? I will enroll him in a cohort study if he gives his informed conscience. And also he will benefit from the study, being that he has a financial constraint and might benefit from waivers for both investigations and treatments and may be applicable to the study participants. But if he is severely depressed, like we're told in the question, such that he lacks the requisite mental capacity to give informed consent, he wouldn't be enrolled in the study. What are the poor predictors in patients with CKD? Patients with CKD, the poor predictors for progression, or is it poor? Hello?
You have 1 more minute.
Okay, the poor predictors include age, uncontrolled hypertension, increased obesity, increased salt intake. From some other papers that I saw online, you have genetic factors, male sex, and lower eGFR spectrum, low serum albumin, and all. So briefly, I would have loved to talk about teamwork, which is definition of a team is a group of people with complementary but varied skills and knowledge expertise that is contributed towards achieving a team's goal. Team means together everyone achieves more. Interdisciplinary multidisciplinary teamwork in health is an important model for delivering holistic healthcare to patients. It is important in the sense that helps improve the quality of patient care and enhance patient satisfaction. It reduces the workload on the different healthcare teams managing the patient and reduces the burnout that health professionals encounter. It's also essential for patient safety as it minimizes adverse effects and medical errors. There are stages to building teamwork as identified by Stockman. They include forming, storming, norming, not morning, and then performing. Forming is whereby a team come together to form a team, try to first of all start and then know what they are there and what they want to do. Storming, they will brainstorm to know what are the ideas, how are we going to tackle a perceived problem. Norming, they try to now arrange the processes together and try to get into the work proper. Performing, the work has started proper and then try to accomplish the task that was given. There are types of team in healthcare: the core team, coordinating team, contingency team, ancillary or support services, and administrative team. The core teams, like in this index patient, is the nephrology team, maybe the cardiology teams, who work directly with the patient in ensuring the patient care. Coordinating team, they coordinate the day-to-day activities of the core teams. And the contingency team, these are teams that come on as emergencies or as events unfold. Like maybe in cases of disaster, you have disaster management team and all that. Ancillary teams could include cleaners and other support staff that help to ensure the smooth running of the team. Examples of teams in healthcare, we have infection prevention control team, have emergency response team, disaster management team, cardiopulmonary rehabilitation team, stroke team, transplant team, and the rest of them. The team characteristics will have skill sets. They are supposed to have a varied skill sets. For those who have same skill set, is not ideal. A team should comprise people with different skill sets, and it could also be the same skill set, but at different levels of the skill set, such that everyone contributes to make the team work, have leadership and authority. In healthcare teams, what is usually applicable or seen is a team hierarchy, but this is a disadvantage to teamwork in the sense that because everybody is waiting for the highest or maybe the next person above to take the final decision, it tends to delay or even cause problems with the activities or the tasks. But when you have a democratic team whereby everybody has an equal standing and gives his or her own opinion, it encourages more open communication and then a more active participation. Team stability, when you have team that is stable and probably has run over a long time, the members tend to know each other more and work together more compared to when you have a transitory team whereby they just come together, work, maybe occasionally, they don't get to know each other very well, and there's room for conflict. Team should have a common purpose. Like I've said, there should be inclusiveness. People shouldn't be discriminated against in the teams. They have roles and responsibility, and the team location is better. You can have team within the same hospital or distributed teams, but they can work together virtually or even come together from time to time to work. And then team size, there's no definite size for a team. The smallest team can be a group of 2 people, or it can, but adequately, you can have about 6 to 10 members in a team. These are attributes of an effective team. Obstacles to effective teamwork, like I've mentioned before, healthcare hierarchies. Okay. These are some of the individualistic healthcare, whereby some people tend to keep the patient to themselves and wouldn't want to share information with the other members of the team. These are ways we can overcome barriers to teamwork, like effective communication strategies, creating democratic teams, like I've said before, and use of simulation during team trainings. So in conclusion, multidisciplinary team approach to healthcare improves health outcome, enhances patient satisfaction, ensures a more efficient use of resources, and enhanced job satisfaction for the team members. Thank you very much for your attention.
Thank you so much, Dr. Faith, for that beautiful and detailed presentation. Okay, so we'll take comments and questions from the participants first. Okay, you can raise your electronic hands. I can drop a comment on the chat. Okay, so and let's get the things coming. Dr. Ede Pharmacist, thank you, Chief, for the presentation. Abdominal ultrasound scan is important here too, among other reasons, including polycystic kidneys. Okay, then for the predictors in CKD, I wanted to add, did you say hyperkalemia? And then for the age, I saw age greater than 50 years. I don't know if you came across such.
Thank you for the comments and questions. For the predictors of kidney disease and progression of CKD, I saw age. There are different age from different sources I looked at. Some said from Italian studies, they got age more than 65. Some others said age more than 50. And I even saw age more than 75. But the constant thing there is that with increasing age, there's risk of progression in CKD. I don't think I mentioned hyperkalemia or hypokalemia, rather.
All right, thank you. So, okay, so I can't see any electronic hands up. And then you have a lot of things on the chat.
You project the question while people are commenting.
Okay, because of time, I think I'll hand over to you.
Okay, thank you.
Yes.
Okay, somebody just asked a question. Dr. Faith.
Okay, let me take the question. Dr. Olarewaju says, well done, Chief. Is cardiorenal syndrome not possible?
Okay, thank you for the question. Cardiorenal syndrome is possible, but the clinical presentation that was given was just things that point towards at first you may think it's just cardiovascular, if not that there was urea and creatinine elevation included there. Cardiorenal syndrome is also possible in this patient. It could be, there are different types of cardiorenal syndrome from Z type 1 to type 4 or 5. And it could be any of them. It could be had CCF and developed cardiac renal complications, or had renal and developed cardiovascular. Either of them is possible. So thank you for that. I think it's possible.
Dr. Florence, go ahead, please.
Okay, good morning, facilitators, senior colleagues and colleagues. Okay, sorry, can you just take me to the prognostic factors for CKD? Let me just see whether you added all that I have here. Thank you. Okay, like an add-on to that, hyperuricemia is also a poor prognostic factor for CKD. Then dyslipidemia is there. Then persistent inflammation is also there as well. Then a background cardiac disease. So dyslipidemia, hyperuricemia, and then a background cardiac disease and persistent inflammation are poor prognostic factors for CKD. Then secondly, and there was a question about a cohort study. I don't know, I didn't really get you so well there, whether you will do a cohort study or not.
A cohort study. The question on cohort study, would I recruit him into a cohort study? So I understand it as, would you enroll him in a cohort study? If yes or no, state your reasons. That was the question.
Okay, so
felt that. Okay. Please ask your question.
Okay, no, I just wanted to know. I just wanted to know your reasons. what I can add on there.
Okay, the reason I gave was that if he gives an informed consent to be included in the cohort study, I would enroll him. But if he doesn't, or probably if he lacks the capacity to give informed consent, then there will be no need to enroll him. That was the reason I gave.
Okay, I don't know from my own angle, I don't know if that is what it's supposed to be. So, okay, I was thinking, okay, if, yes, okay, you can actually enroll him in a cohort study because, you know, the disease is actually a disease that progresses, as in that is a disease that progresses over time. It has a slow progression in the disease. So if you enroll him in a cohort study, I think it will be beneficial because you kind of estimate the pattern that's looking at the functional aspect, the structural aspect of this patient over time, whether there's any change in the functional aspect of the kidneys, if there's any change in the structural aspect of the kidneys, because I think it was trying to depict polycystic kidney disease, whether the cysts are increasing, and to just know the progression of the disease, and also to look out for mortality rates over time, like how many people with this disease will come down with death fatalities and all. And also maybe to look out for family members. You know, if you're thinking of a polycystic kidney disease, you actually have to screen the family members. And you know, sometimes you can actually do an abdominal ultrasound scan and you don't see anything, and then you need to go further to do genetic studies, maybe to look out for family members, also to know how many of them eventually will come down with the polycystic kidney disease. That most of them who were symptomatic initially, over time, would they come down with the polycystic disease after doing a genetic study on them? So I don't know if it's in that context that they were asking. So that's just what I have to say. Thank you so much for a beautiful presentation. Thank you.
Okay, thank you so much. Your comments are well taken and noted.
Thank you. Thank you, Dr. Kalamama. Thank you, Dr. Faith. Surprised we've not been hearing your voice. You are quite eloquent. That is a very nice voice. Please, I want to appeal to you. Sound like someone that has so much information to deliver and give. Please share such information with us, please. Please want to be hearing more of your voice. Thank you so much. What's your specialty, please? If you don't mind sharing.
Cardiology.
Cardiologist are doing well. So thank you so much. Please, I appeal again. Let's hear your voice more, please. That is nice, soothing voice. So thank you. Thank you, Dr. Fatima. I wanted to go ahead. If I call Chief Chitu and Remigus, they're coming.
Thank you.
Fatima, go ahead, please.
All right. Thank you very much, Doctor, for the wonderful presentation. My point is regarding this predictors of outcome in this patient. You have to look at the question. This is a patient with financial constraints. So financial constraint is a predictor of poor outcome in this patient. So whatever answer you are given, it has to be in regards to the question. Then the psychological disturbance he's having, then delayed initiation of hemodialysis. These are all predictors of poor outcome that you didn't mention. So these are social issues that are very relevant. So if they ask you the question, what are the predictors? You can't just start mentioning anything. No, start from what is mentioned in the question. If you are talking out of point, they'll try to bring you back to track. Yeah, thank you.
Thank you so much, Dr. Fatima. Before I call on Chief Chitu and Remigus, I wanted to just make a comment quickly. This particular F question, the question was, would the patient benefit from a cohort study? Give your answer and defend your answer, something like that. You're not supposed to give two answers. You're supposed to give one. Maybe because it's discussion, that's why you gave us two. You're supposed to give one answer based on the scenario they've given to you. You're supposed to give one answer and defend it. When you start going left, right, some of them get a little irritated. So just choose one. For those going for these exams, please choose one and defend it. But remember, look at the clinical scenario, the patient that was set before you, and answer the question. But based on what you said for this particular patient, the financial constraint and all is yes. So please, if you are asked something like this, go for one answer. But I believe it's because you are presenting here. That's why I give us two. So thank you so much. Chief Chitu, Chief Remigus, I don't know, Chief Cookie. I don't need any comment. Dr. Kopi.
Hello?
Yes, sir.
Well, I expect Dr. Shitu to talk, but let me talk before him. I think actually initially when it started, I didn't really get the question very well, so but I just caught in the middle. But I wanted to weigh in on the factors for or poor prognostic factors. Okay, so at least most of them have been mentioned, but please don't forget malnutrition. Okay, malnutrition is a known poor prognostic factor. Okay, protein energy wasting, they have been giving it so many different names these days, but malnutrition is important. And then yes, cardiorenal syndrome is very is a good, well, people is an acceptable diagnosis, but most cardiologists and nephrologists these days we're trying to calm down on making the diagnosis, because a lot of times it's so non-specific. You don't really know what you are managing, but it's important to know it, and you must know the types from type 1 to type 5. Type 1 cardiorenal syndrome is acute cardiorenal syndrome. Okay, so in type 1, that's when an acute cardiac event like an acute heart failure causes a kidney derangement or kidney injury. Okay, it used to be called acute heart failure causing acute kidney injury, but because of some other things that can come in between, we don't like to say it has to be acute kidney failure or acute heart failure. Okay, because an acute MI2 may actually cause that, and it's not heart failure. So where would you put that one? So we usually just say acute cardiac event causing an acute kidney injury or an acute kidney problem, or causing a kidney problem. Of course, if it's acute, it's likely to be an acute kidney problem too, because the inciting event is acute. Okay, so that's type 1, acute cardiorenal syndrome. In type 2 cardiorenal syndrome, that is chronic cardiorenal syndrome. So in that one is a chronic cardiac problem, like a chronic heart failure causing a kidney injury. Okay, it used to be termed chronic heart failure causing chronic kidney disease, but we found out that it doesn't have to be chronic kidney disease. What if it's an acute kidney injury that is causing, even though it is chronic heart failure or whatever, or it's just left ventricular hypertrophy without actually causing, so it doesn't have to be a chronic too. So, but that's just chronic cardiorenal syndrome. That's type 2. Type 3 is acute renocardiac. So now it is the kidney that is the inciting event causing a cardiac event. So acute renocardiac syndrome, that is type 3. Okay, so you have an acute kidney injury causing maybe an acute heart failure, an acute decompensation of the heart or whatever. Okay, so that is acute renocardiac syndrome. While type 4 is chronic renocardiac syndrome, where you have a chronic kidney disease causing a cardiac event like heart failure, but it can also be acute heart failure. That's the reason why we don't want to say chronic again. So it's type 4 is chronic renocardiac syndrome, while type 5 is a systemic event causing both a cardiac and kidney injury. Okay, so that's for the cardiorenal syndromes. So I wanted to say that. Now, I also agree with Dr. Kalamama concerning the cohort study. A CKD is a progressive illness. So when you enroll this kind of patients into a cohort study, it can help you study many things: the natural history of the disease, the cause of the disease, mortality, morbidity, prognosis. There's so many things that one can study when you follow these patients up, possible complications that they can have. So a cohort study is actually a very good study for patients that have progressive diseases, okay? Especially ones that there is minimal management for, okay? So you can actually study them without breaking too many ethical principles, okay? So, you know, if somebody has a disease condition that you can treat, you can't be watching the person. You have to intervene. Okay, so even sometimes that one too, you can enroll in cohorts, then put your intervention and then watch the outcomes. So it's part of it. So you can actually test novel remedies, novel treatments, options, you know, on people like that. The diagnosis has been made that this person has CKD, which everybody knows that is an irreversible disease. In quotes, let me just put that in quotes. Okay, so this kind of disease, people can bring up, you know, studies, researchers can bring up novel remedies and want to try it out on people like this, especially this kind of patient who does not even have money for other forms of renal replacement therapy. It can even be enrolled into a program that involves, or into a study that involves maybe giving kidney replacement therapy and observing the outcome, you know, comparing it with other forms of kidney replacement therapy and all that, comparing outcomes. So it would be she's a very good candidate for a cohort study. So I think these are the things I wanted to contribute. Thank you so much.
Well, thank you so much, sir. Thank you. Chief Chitu, any comments? Any comment from any of our facilitators before we close the class? Okay, I think we're all good. So thank you so much, everyone. Thank you.
I think Dr. Chitu was locked out. He's no longer there.
Okay, he's not here, so he's not anywhere. Maybe got busy or something. So thank you, Dr. Faith. Thank you, Dr. Ekele Kalamama, and Dr. Temitope and our participants. We appreciate you all. Our facilitators too, we appreciate you. If I'm good, please just close the class for us. I will leave.
All right. So thank you, people. You guys have been awesome today. And my love for this class continues to grow. You guys are impressing me. You're doing well. Presenters today were beautiful. The contributions were awesome. Dr. Kelly Roberts, Kalamama, you guys are just awesome. So I've been enjoying myself attending this class, and I hope it continues like that. So let's just keep it on. Let's keep on talking. Let's keep on presenting. Let's keep on contributing. In fact, I'm sure all of you know that you're already improving. You're getting better as not just as doctors, but as people. Now you are learning how to counsel. You are learning how to talk to people, how to relate to your patients. You're getting better every day, and that is what being a doctor means. It's good. It goes beyond passing your exams, and that's why some of us are still here. So I encourage all of you. Let's just keep on doing it. The exams will be a breeze when we participate here, I assure you. So let's just keep on doing it. God bless you all. Have a beautiful day ahead. Bye for now. See you tomorrow.
Thank you so much, sir. I appreciate you, sir. Thank you, thank you, thank you. Thanks to our facilitators once again and everyone. We meet in class tomorrow. Have a wonderful day.
Thank you, ma'am. Thank you, sir.